You might be on
And
mute, Fran.
yeah, hello everyone, and welcome to the Match Coalition. Thank you for that. The Match Coalition stands for the Maternal Applications of Technology for Community Health. And we are so honored to be able every year, in fact, twice a year in the spring and in the fall, uh, to offer our virtual Heal briefing. And it's an honor for us today because we have some amazing guest speakers who are going to be participating with us. We're just delighted to introduce them. Before we do, we always like to begin with giving folks the opportunity to make any announcements of any national, state, or local initiatives that may be going on in their neck of the woods that they would like to share with everyone. Anyone have any updates on any national programs? Any incredible happenings there in the state of New Jersey these days? Dr. Buckman, anything going on there?
I can't think of anything offhand. We're certainly doing a lot through climate environment for mothers through the One Health initiative, but that's basically what we've been doing at this point.
That's wonderful. And here on the West Coast in California, we are hunkering down in terms of and doubling down on ensuring that the programs that are being offered to support moms and the technologies as well that are available to enable that continue to move forward. So we're very excited about that. But I think, as you stated, Dr. Buckman, business as usual these days and just trying to orchestrate and streamline as much as we can as well to make for more efficiency so that we're able to reach more mothers, more families everywhere. So thank you for those updates. Again, it's great to see everyone today, and I'm excited to get us started. So we are going to be moving into our special guest speakers for today. As a reminder, with the virtual Heal briefings, we do put a hyper focus, a spotlight, if you will, on very important topics. And every session they change, and today would be no different. We recognize that maternal mental health is a challenge for many moms, and the rates of which, unfortunately, continue to soar, and that we need to be more creative and collaborative in the efforts that we take to address those issues. Equally, we acknowledge that availability of resources to address those issues is not always easy. We often think about urban versus rural. We forget that we also have highly, I don't know if transitory is an appropriate word, but certainly we do have transitory populations, folks who are moving around quite a bit. One group in particular, a group that we honor, and if you don't honor that, we would encourage you to honor, is our military and the work that they do. And we oftentimes get forgotten because they are often moving around from place to place. And they are separated from their family and surroundings often that are familiar to them. So we thought, wow, I just get kind of goosebumps, honestly, just thinking about it and what that means and how important it is that we begin to talk about it and start to think through ways that we can address challenges, but also to celebrate successes as well. And in order for us to do that, we need to get ourselves a little bit more educated. And so I'm excited, as well as absolutely honored, to be able to introduce you to today's guest speakers. I'm going to begin by introducing Adrienne Griffin. I'm going to just put you, Adrienne, on the spotlight for everyone. Welcome, welcome, welcome. Thank you for joining us. Adrienne is the Executive Director of the Maternal Mental Health Leadership Alliance, and it's a pleasure to have you with us here today.
Thank you, Fran.
Adrienne,
It's a delight to be here.
yes, thank you. And Adrienne is equally, is joined by another fantastic guest speaker whom we're also going to spotlight, and that's Dr. Sarah Roscoe, who is the Behavioral Health Medical Director for Humana Military. I couldn't think of two better subject matter experts and leaders within the space to bring together for today's program. And welcome and thank you, Dr. Roscoe and Adrienne. I'm going to hand it off to you to introduce yourselves and share a little light on this very important topic.
Great. Well, thank you so much for welcoming us and for taking on this really, really important topic of maternal mental health. And so we are going to do a little, I'm going to start the presentation and then I'm going to pass it over to Sarah and then she'll toss the ball back to me. But Sarah, why don't you go ahead and introduce yourself?
You bet. Hi, I'm Sarah Rasco. I am a psychiatrist and a behavioral health medical director at Humana Military. Humana Military is the managed care support contractor for the TRICARE East region. And TRICARE is the healthcare benefit for active duty service members, their families, and military retirees up to a certain age. So that's kind of how I arrived arrived at today's presentation. Previously, before joining Humana Military, most of my work was in community mental health clinics with populations that had serious mental illnesses and in some forensic spaces. So that's my background, and I'm calling in from San Antonio, Texas, and so pleased to be here.
And Sarah and I have been working together over the last year or so on some initiatives to support the mental health and well-being of our nation's military mothers. So really so grateful to be sharing the stage here with Sarah. And I have led the Maternal Mental Health Leadership Alliance for the last 5 years. We focus pretty much on national policy around maternal mental health. My work is fueled by my lived experience. I had significant postpartum depression and anxiety about 25 years ago when one of my children was born, and it took me a long time to get the help that I needed. And so I switched careers and decided that I would become a patient advocate and have spent the last 20 years or so working in the field of maternal mental health. So this is the topics that we'll be discussing today: maternal mental health and its impact for both rural communities and military families, and just a few of the bullet points that were shared previous to this call to make sure that we stay on track. So I'm going to start with just a quick overview of maternal mental health, the facts and figures, just to orient all of us. So having a new baby, often the happiest time in a family's life, right? I love all of these pictures. All the babies are sleeping. All the moms and dads look well rested. Everybody looks happy and peaceful. It's all so beautiful. And not always. It can be a little bit of a disaster. Actually, at my house, some of these pictures are actually from my house. That's my daughter on the bottom having her 2-year-old tantrum. It was a bit of a shit show. I'm not going to lie. It was much harder than I thought it was going to be. And again, that's why I have decided to devote the second half of my career to really supporting the mental health and well-being of our nation's moms. So maternal mental health, a quick overview of the facts. Would it be surprising to you to learn that mental health conditions are the most common complication of pregnancy and childbirth? They actually impact at least 1 in 5 individuals during pregnancy and the first year following pregnancy, or the first year postpartum, and even more in high-risk communities like our military moms and moms who live in rural spaces. And tragically, suicide and overdose combined are the leading cause of maternal mortality. And whenever I say that, it's almost like I have to catch my breath. Like, how is this possible in the United States in the year 2025 that mental health conditions are both the most common complication of pregnancy and childbirth and the leading cause of maternal deaths? That's a little bit sobering. So what are we talking about when we talk about maternal mental health? So it's a wide range of mental health conditions, not just depression and anxiety, but also bipolar disorder, OCD, PTSD, substance use disorder, and in very rare cases, psychosis. And it's really a 2-year time frame. So from conception all the way through that first year postpartum. And so many people are familiar with the term postpartum depression, postpartum meaning after the baby is born, and depression, obviously sadness. But what we like to say, it's not just postpartum and it's not just depression. So it's really this 2-year time frame and a whole host of mental health conditions. And so why do we care? What is the impact? Well, the vast majority, as many as 75% of those impacted by maternal mental health conditions, remain untreated. And this increases the risk for negative impact, not only on the mother, on the baby, but also on the entire family. I know, for example, that my postpartum rage was very targeted at my husband, and it took a long time for him to recover from that. And we also know that there's a significant cost to these untreated illnesses of $14 billion, that's B, billion each year in untreated maternal mental health conditions. So that's the impact on the mother as well as the impact on the baby. So what kind of impact are we talking about? So here's a quick look at women with untreated maternal mental health conditions and how they are impacted. So during pregnancy, they are less likely to manage their own health. They may not attend their prenatal visits. They may have poor nutrition, and they may use substances such as alcohol, tobacco, and drugs to self-medicate. These women are also more likely to experience physical, emotional, or sexual abuse either during pregnancy or that first year after the end of pregnancy. And then these moms are likely to be less responsive to their baby's cues. They may not be in tune with their child. They may be overparenting and anxious, or they may be withdrawing. So they're likely to have fewer positive interactions with their baby. They are also more likely to experience breastfeeding challenges, as well as to question their competence as mothers. And what is the impact on the baby? Well, children born to mothers with untreated maternal mental health conditions are at risk for a whole host of poor birth outcomes, including low birth weight or small head size, preterm birth, and longer stays in the NICU. So these are all the things that we don't want for babies. And then when they come home from the hospital, they may experience excessive crying. And remember, if that mom is not in tune with them, the mom may not be reacting or responding. And so the baby becomes fussier. And so it's sort of this negative feedback loop. This can lead to impaired parent-child interactions, which then can have long-term impact on the behavioral, cognitive, and emotional health of children. And we know that untreated mental health conditions in the home can lead to adverse childhood experiences. So it's really the perfect storm, all of these things that come together. So these incredible hormonal changes that women go through during pregnancy, labor and delivery, and in that immediate postpartum period. You add on sleep deprivation. This is often the single biggest identity transition for parents. There's all those unrealistic expectations. Remember those beautiful photos that I showed earlier, like everything's supposed to be perfect. Nobody expects that they're going to have any difficulty in pregnancy or birth. If somebody has a predisposition for depression or anxiety, it's heightened during this time. And then any lack of access to healthcare, which the two groups that we'll be talking about today, both military mothers as well as rural moms, face some challenges sometimes in accessing specifically mental health care. So I'm going to turn it over to Sarah here to talk about military mothers, the unique challenges and opportunities that these women face.
Wonderful. Thank you. Let me first say that I love having this conversation because it's evolved and is so much more kind of nuanced and complex than it was when I was in training. Granted, that was a couple decades ago, but as Adrienne said, we really used to focus on postpartum depression. So that specific condition to the exclusion of that pretty big list of other conditions that can happen: anxiety, OCD, eating disorders, substance abuse, and I think we also neglected the pre-partum period. So that's the chance when you get to catch early symptoms and equip women with really effective tools and effective treatments, barreling towards delivery in the postpartum period. So having said that, let's think about our military population specifically. So who are our military mothers? In the armed forces, there are a little over 100,000 births every year. So about 17% of those women are active duty service members. And then the remaining are either the spouses of active duty service members or the women are veterans. So a pretty sizable population that we have to worry about. Adrienne, can you go to the next slide? Thank you. Okay, so these women we are concerned about because they are at increased risk for maternal mental health conditions compared to their civilian peers. And in fact, 36% of TRICARE beneficiaries experience a peripartum mental health condition. We'll go to the next slide. So certainly we're concerned about the distress of the woman and the impact on the infant. But if we think beyond that, the effect on the family system, on the spouse, as Adrienne alluded to, on other children in the family. We worry about them as well. Also, in the military, if an individual in a military unit, if you think about unit cohesion, if an individual in their family is struggling, it can affect how the unit is functioning and prevent them from being able to kind of operate at the top of their game. And that can impact readiness. So when we say readiness, we mean ability to serve and to carry out the functions that we rely on the military for. And so when you all, help us advocate for solutions and represent this population, it's not an exaggeration to say that this is a matter of national security, right? Okay, next slide. So knowing that women in the military are at increased risk for peripartum mental health disorders, we want to find an explanation, but there's not a single answer. But if we think through kind of military culture, maybe that'll point us towards some answers. So first of all, we know that 50% of mothers with deployed spouses do experience postpartum depression. We also know that women service members who have been deployed experience maternal mental health conditions at twice the rate of non-deployed women. And especially concerning statistic is that about 40% of women service members report having experienced sexual assault. Next slide. So as a part of service and of being committed to the military, families and women frequently move. That's part of the experience. And so with that, frequent moves are stressful. It can remove you away from your family of origin. It can disrupt family structure and routines, and it can lead to a perceived lack of social support. Certainly military members or family members are concerned about a service member being in harm's way. And if you think of dual military relationships, so if a couple are both active duty, that can kind of compound the stressors of service. Next slide. The commitment to the military and service requires service above self or before self. That's part of the culture. The military is also quite hierarchical and has been traditionally male dominated. It requires discipline, professionalism, and strength. And that can lead to the perception that showing emotions, seeking help related to emotions can be equated with weakness. And so that can prevent people from showing emotion, from sharing struggles, and for seeking help. Next slide. And so the impact on female service members specifically, they're certainly generally there's a stigma. There has been a stigma surrounding mental illness. I think that is getting better, but in the military, there's the possibility of stigma related to mental illness, but also associated with gender. So showing emotion, being vulnerable, feeling fear, seeking help can be associated with femininity. Wow, I can't say that. Sorry, with being feminine, and rather than the masculinity that kind of underlines the military mindset. All right, next slide. So the great news we have to share with you today is that there are really effective treatment options in the form of psychosocial support, evidence-based therapies, and or medication. So that's great news. But unfortunately, many women in the military still suffer. And So we want to get at the barriers to care, right? So some of those barriers can be just general knowledge about the availability of resources. There are actually wonderful resources within the military, but you got to know about them to access them. Stigma again, and then good old logistics. So when people have competing time commitments, caregiving commitments, geographic barriers, all those can prevent women from recovering. In terms of the provider side, um, so if a provider doesn't ask, if we're not screening and asking questions about how women are doing, then we're depending on them to self-report, right? And so it's critically important to be asking questions about how women are doing. Excuse me. And a lot of times what's behind that is that the provider themselves doesn't have adequate resources to offer. They kind of don't know what to do with if the woman expresses distress, right? So knowledge, time, and resources, we need to make sure that the providers are fully equipped with those to be able to offer care when they have the opportunity. Next slide. So what can we do? So I think Adrienne will speak more to this, but I'm going to give you a kind of cheating answer, and that is, if you follow her organization, you will be up to date on the most recent legislation, facts and statistics, and all the exciting developments that are happening towards connecting women with much needed care. So make sure that you see that website at the bottom of the page. Sign up for newsletters, check out their fact sheets, and you can help us be critical advocates for military mothers getting much needed care. All right, back over to you.
Thank you, Sarah. So one of the reasons why my organization is so committed to this issue is that I served in the military. And so I know firsthand what it is like to be a woman in the military, to experience mental health conditions. And so when I came to MMHLA, I knew that I wanted to help raise awareness and focus some resources to help support the mental health and well-being of our nation's military mothers. And so about a year and a half ago, we started really digging into this work. We produced a fact sheet on military and veteran women and their mental health conditions. We had a webinar. We've been speaking at many conferences about this topic. We've created a roundtable to convene experts and allies. We met last year in person in July. We've had several meetings virtually over the course of the year, and we are reuniting on July 21st in the Washington, D.C. area. If any of you would like to join us, please let me know. We also have introduced some legislation that was included in the FY25 National Defense Authorization Act to launch a maternal mental health program within the military. And so we are sort of addressing this from many different points. But again, we know that our nation's military mothers are at increased risk. They have unique circumstances and experiences, and so therefore need some unique interventions. And so we are really committed to working with Sarah and others in the TRICARE system and in the military health system to make sure that these moms get the help that they need. So really, really super excited to be doing this work. So another group that we've been asked to talk about, or a group that also experiences unique challenges and opportunities, are rural mothers. So, of course, the big issue in people living in rural populations or rural areas is access to care, right? With geographic isolation, there may be limited healthcare infrastructure or workforce shortages. People who tend to live in rural areas tend to also be less economically situated. And so there's just a variety of issues that impact their access to care. And so we talk about maternity care deserts, and this is really the area of expertise of the March of Dimes. They do a lot of research into where women and families can get obstetric care. So over a third of US counties are considered maternity care deserts. And what does this mean? This means that there are no birthing facilities, no hospitals that provide obstetric care, not even any obstetricians. This is a third of the counties in our country. And this can increase the negative outcomes for both the mother and for the baby. So what kind of negative outcomes? Well, these women, because they have not necessarily had access to health care, they may enter pregnancy with poorer health conditions. They get less prenatal care, so they're not seeing the doctor once a month during their visits. They may have to be doing telehealth visits, which we know is convenient. They may not be as effective as in-person visits. And this all can lead to the risk of higher rates of preterm birth. And again, this is all information from the March of Dimes. So what the March of Dimes has actually done is map out these different counties where there are maternity care deserts. So the red are where the maternity care deserts are. So that's over 1,000 counties in our country. And then we see the purple, the orange colors are where there's more access to care, and the purple is where there's full access to maternity care. So as you can see with most things in our country, resources are kind of, along the coasts, and we see the center of our country where most of those maternity care deserts exist. So I just wanted to look at a couple of states because, again, the March of Dimes does all of this work on a state-by-state basis. So I just picked Texas at random. It's one of the largest states in our country, both geographically and in terms of population. And you can see where, so in this case, the dark blue is where there's access to maternity care, and the light blue is where the maternity care deserts are. So again, you sort of see kind of in the center part of the state where it's more rural and where there are maternity care deserts. I just looked at a couple of other states. Here's Oklahoma, and each state uses different color coding. In this case, the darker red are the maternity care deserts, and you see so that most of Oklahoma has maternity care deserts. So again, that means that there's no obstetric providers, there are no birthing facilities, there are no hospitals that have obstetric units. And then I selected Virginia because I thought they did a very interesting way of representing this. So they show of the 28 rural hospitals in Virginia, which ones do not have maternity care units. So the sort of that teal colored are the hospitals, but they do not have maternity care units. And so we see that like a vast majority of the state, again, there are no hospitals and there are no maternity care situations. So these are women who then either have to travel or who deliver their babies in the emergency room. Okay, so again, if you want to learn more about the challenges that rural mothers face, I direct you to the March of Dimes. This is really their area of expertise. This website that I've linked here has stories from families like the couple on the left, as well as from providers who work in these maternity care deserts. Okay, so let's talk about some solutions. We have highlighted the problems that we always want to, bring it back to. So what are we doing to help these moms? So one of the things that we did at MMHLA was that we convened a technology council. So over the last couple of years, we heard more and more about digital behavioral health, kind of the work that you all are doing. And we were like, what does all of this mean? We would read, like they're impacting the ecosystem and, doing so what does this mean? So we invited 10 companies to join our technology council. These are all companies who focus on providing care to mothers either during pregnancy or in the postpartum period, and a variety of different interventions. Some of these companies actually provide care directly to the patient, and some provide support to the providers. So I think that's my next slide. Yes. Okay. So I'll talk about the companies that provide direct support to providers. So these are companies whose digital interventions can help with things like screening. So for example, if a mom comes into the office or if it's a virtual visit, right, she can fill out a screening tool in advance. It's immediately incorporated into the patient's record, and the provider will get a heads up, hey, this patient screened at risk for X, Y, or Z. So the provider knows the result of the screen before they even go in to see the patient. It can help with workflow. It can provide resources and referrals to those providers who can then pass them on to the patient. And they can help with a system of care called collaborative care, which is basically where mental health conditions can actually be treated by mental health providers in the primary care setting. So what this would look like in an obstetric care setting is that perhaps there would be a social worker embedded in that obstetric practice, maybe even a psychiatrist, depending on the size of that practice, but and there would be care coordination. So like all of the mental health care is actually provided right in through the obstetric practice. Some of the companies in our technology council provide direct support to patients. And what this often looks like are primarily three things: social support, so whether it's a peer support or a support group, one-on-one peer support, but it's really helping that patient sort of normalize and feel like they are part of a community of others who are experiencing the same issue. Often one-on-one therapy or coaching, and in some cases, medication management. And so, for example, I'll just back up for a section. So, for example, company 7, Starling, provides all of those services directly to the consumer. And then companies like Concert, and where's the other one? And FamilyWell, they provide the support to the providers. And so we brought all of these companies together to help us understand the ecosystem more, but also so we can share information about these companies. We've vetted them, we value what they do, we know that they know what they're doing, so we can share and uplift these companies, particularly in how they address maternal mental health. And so one of the things that we did was last week, we were able to bring several of these companies to Washington. We had met with the Congressional Digital Health Caucus earlier this year and said, hey, we have this great technology council focused on maternal mental health. And so they invited us to come and do a briefing. So we had several of these companies come to town, did a lunch briefing and a panel discussion. We also were able to have some meetings with folks at the Chamber of Commerce, at the FDA, and within HHS with the Assistant Secretary for Technology Policy. And so our policy director, Jamie Belstito, was the one who brought these folks around. They also met with some members of Congress to help elevate these issues and talk about, any regulatory issues that may be impacting their work. So we were eager to it's sort of like a, reciprocal or reciprocity, like, they help us, we help them. We were able to help elevate their companies and their issues. Okay, so back to how can these therapeutics then help people who live in maternity care deserts? So I went back to Texas. And so again, on the left, I've circled where the maternity care deserts are, kind of, again, lumped in the center of the state. Unfortunately, when you look on the right, which is a map of broadband access, we see broadband issues, or lack of broadband, I should say, sort of in the same area. So we have this, we keep thinking that technology is going to solve all of our problems. But if folks living in those rural areas don't have access to a computer or a phone or internet, we're still not getting there where we need to go. So what are some other solutions that we can offer? So we started looking at some policy issues. So the HHS, the Department of Health and Human Services, actually launched a project called the Rural Maternity and Obstetrics Management Strategies, called RMOMS, to increase access to maternity care in rural settings. So the whole idea is start to address some of these barriers to care in rural settings and to collect data, to build networks, to leverage telehealth and specialty care, and to improve financial sustainability in those particular areas. We also looked at what other resources are available for moms that are like good old-fashioned telephone. So one of the first things that I advocated for when I came to MMHLA was the National Maternal Mental Health Hotline. I remember being up in the middle of the night with my son when I was experiencing postpartum depression. It was the middle of winter. It was dark. It was cold. I was up every 2 hours. I thought I was the only person alive and awake in the middle of the night, and I desperately needed to talk to somebody. And there was not a hotline. There was no number to call. This was before cell phones. And so when I came to this job, I said, we need a 24/7 hotline that moms can call anytime, anywhere, text or voice. And so we created the National Maternal Mental Health Hotline. It has been up and running for 3 years now. It's helped over 60,000 mothers and families impacted by maternal mental health conditions. Counselors provide free confidential support, encouragement, information, and resources. And so this is something that anybody can access anywhere, anytime, even like through an old-fashioned phone. The other resource that I always hold up is an organization called Postpartum Support International. This is where I started many years ago when I first got involved in this work. I started as one of their volunteers in Virginia. PSI provides many different types of support to moms and families impacted by maternal mental health conditions. They have a warm line where somebody can call and leave a message, and then they'll have a volunteer return your call from from your state or from your region so that they can provide as many local resources as possible. They have volunteers in all states as well as state chapters. They have special volunteers and support for our military moms. They have what they call support coordinators from each of the military services, including the Coast Guard, the Space Force, Army, Navy, Air Force. There is an online provider directory that you can search for providers in your area. You can also search by insurance. So again, our military folks are looking for folks who accept TRICARE insurance. And they have over 30 online support groups. And again, one specifically for military moms, one for rural moms. They break it out in, all different combinations of specific needs, like parents who have a baby in the NICU. And so I encourage you, if you're interested in learning about more of these supports, to check out Postpartum Support International, and there is their website. All right, so that is the end of our formal part of our conversation. Again, there's information for both Sarah and me. We welcome your questions today now, as well as via email. So I'll leave this up for a second in case you want to copy down those emails, and then we can looking forward to engaging in discussion and hearing your thoughts, answering your questions. And I'll turn it back over to Fran to help moderate.
Wow, thank you. What an incredible presentation, and just a wealth of knowledge and resources all the way through. I myself have so many questions, but before I jump in, I'm going to actually invite others to join us. Anyone who has questions is welcome to join us here, and as well as pop your questions into the chat window. We are excited to be able to really deep dive into just from A to Z on all the things that you have presented to us today. I think to start us off, I would like to go back, if you don't mind, for a moment. It's such an important statistic, and sometimes statistics get misrepresented or misspoken. I want to, if you don't mind, if you will indulge us, Adrienne, I'd love to hear it again. The statistic on the ranking of maternal mental health amongst the contributors to maternal mortality and morbidity.
Yeah, so
Can you
thank
repeat
you.
that number? Mm-hmm.
Absolutely. And I actually was going back to my slide. I'm going to share that slide again just so everybody can see it. So mental health conditions are the most common complication of pregnancy and childbirth, impacting at least 1 in 5 individuals. And they are the leading cause of maternal mortality. In fact, they account for about 22%, almost 1/4 of pregnancy-related deaths. So that means deaths during pregnancy or in the postpartum period. 23% of pregnancy-related deaths are to suicide or overdose. And that is just tragic because all of those deaths are preventable.
That's an unbelievable number. And, it really makes me pause and think, right? That when we talk about 80% of maternal mortality being preventable, we have to stop and ask ourselves why. And we point to a lot of things, right? But seldom do people point to maternal mental health and the signs and symptoms, which you guys presented. I mean, you presented these on stage. What are your thoughts to this notion of the degree of preventability, right? How preventable this truly could be? And Adrienne, if you'll kick us off, and then I'd love, Dr. Rosk, if you jump in and share your thoughts as well.
Sure. So absolutely, mental health conditions should be discussed and talked about from the beginning of pregnancy all the way through that first year postpartum. It should be as common a conversation as discussing things like every time, if any of you have been pregnant, you go see the doctor once a month, and you walk in and you get weighed and they take your blood pressure, and you pee in a cup and they test your urine for all kinds of things. So same thing, they should be asking you, how are you doing, right? This is a very common time for women to experience anxiety or depression. How are you doing? Let's check in. But instead, are because of the way our healthcare system is set up. Number one, doctors don't have time. Number two, they don't get trained in this. Number three, they don't know where to send people to help. And we've separated the head from the rest of the body, right? And so everybody kind of tap dances around your mental health when in fact it should be something that we discuss as easily as we talk about any other aspect of health. And certainly the sooner we can identify that somebody starts to experience symptoms, the quicker we can address them before they become a crisis situation, right? If a mom says, hey, I'm feeling kind of off, okay, let's get you connected with a support group or maybe seeing a therapist, and let's put some scaffolding in place so that mom doesn't fall off the cliff into the pit of anxiety or depression, but then we have to pull her up when she's already at her worst. And Sarah, I saw you nodding, so I'm sure you want to.
Very well said. And I'll just add, when we think bad outcomes related to peripartum mental health disorders, suicide is obviously a concern, but also having a peripartum behavioral health disorder puts you at higher risk of hemorrhage, preeclampsia, stillbirth, many, medical, I mean, they are medical outcomes. So we have to think, a big chunk of bad outcomes that we're trying to prevent. And yes, I think prevention is critically important. So, I mean, also, can you imagine, a woman noticing prior to delivery that, I'm not sleeping well. I've noticed the connection between not being able to sleep well and my mood. I think that's about to get worse. I gotta get some tools. I gotta come up with a plan of how I'm gonna manage this. And then someone presents them with a wonderful tool basket, right? That's kind of the dream, that everybody has access to strategies that are really going to help them do well in the whole partum space.
Yeah, and sometimes those strategies are relatively simple. So for example, maximizing your sleep. And I know everybody says, sleep when the baby sleeps. Sometimes that's not enough. We know that people, generally speaking, need 4 to 5 hours of uninterrupted sleep to operate sort of normally. Well, for a new mom who may be breastfeeding and up every 2 hours for weeks or months on end, that's not sustainable. And so we talk to new moms. For years, I ran support groups and provided direct support to moms. So we would talk about, okay, once breastfeeding is well established, it's within 2 weeks or so, maybe you could give up just one feeding and have your partner or another adult in the home, or a night nurse or whoever could take one feeding so that mom could get those 4 to 5 hours of sleep. And so a lot of these interventions are very, very practical. Set a feeding station next to where you feed your baby so that every time you sit down, you can feed yourself and nourish yourself and replenish yourself. So a lot of it's like very practical interventions. And then of course, therapy, medication for more serious conditions. But a lot of these things we can address because it's just sort of basic self-care that kind of goes out the window when you have a new baby in the home. Yeah, so it's a variety of interventions and strategies. Yeah. So
remember the number, folks. Write it down. Get it to memory. 833 TLC Mama.
Thank you.
TLC Mama. Share it with others. Dr. Bachman, you were going to jump in as well. You were nodding your head as they began to speak about some of these preventative approaches.
I just want to bring up one point, and I want to ask everyone. When you think of pregnancy and having a baby, what are the first thoughts that come to your mind? They're happy thoughts, obviously, that you're supposed to be very overjoyed and happy, especially if this was a wanted pregnancy. And I think in my clinical practice, what I see is that women are sometimes reluctant to talk about the issues they're having or the depression, because then they're saying, you're stupid. Gloria, you should be the happiest person in the world. You're pregnant. You're going to have a little child pretty soon. And why are you depressed? Why are you anxious? Why are you feeling sad? So what I see is a lot of individuals are reluctant to talk about, especially since they often bring a partner with them because they want them to share in hearing the fetal heart tones and all the other things. So how do you address that issue that it's a happy time, but you, Gloria Bachman, may be very sad, very depressed, very anxious, that, you know, you just feel blue.
Yeah, great question, Dr. Bachman. Especially we have to recognize that about 50% of births or 50% of 50% of pregnancies are unplanned, right? So not every pregnancy is wanted and desired. And so I think, you know, from the caregiver perspective, that would be like one of the first questions on the first visit. Hey, how, you know, what are you thinking? How are you feeling about this, right? And then you can, you know, gauge move from that point forward. But I also think it's often, I believe, Adrienne Griffin personally believes, it's really on the provider to raise this issue of mental health. We can't wait for the parent to say that something's wrong. I really think if the provider normalizes it from the beginning and says, look, anxiety and depression are very, very common during this period in life. It's a huge transition. It's okay if you're not feeling okay, because we can help you find help. We can talk to you. We can get you connected with resources. How long did that take? Like 15 seconds to say that? If a provider can sort of level set from the beginning and say it every time that they're checking in on a mom. Hey, remember I said anxiety and depression are very common. How you feeling? Very common. How are you feeling? Doing okay? Great. If not, let me know. We'll get you connected with resources. Again, it like takes the air out of this huge balloon that might be in the room and really then makes it okay for the mom to say, hey, you know what? I am kind of struggling a little bit. Yeah. Not to put one more thing on our providers, but I do think in general, if we could talk more about mental health and if it could begin with the provider, it makes it okay then to talk about it instead of being something that you're ashamed of. Yeah.
That's an excellent point. And, you know, it just makes me go back to the comments you all were making about describing some of the scenarios and thank you, Adrienne, for sharing the very intimate, right, very personal experience of knowing that you needed to call or reach out for help and folks not knowing where to go or where to call. And I think Dr. Roscoe, you articulated that very well with when you shared earlier in your presentation that oftentimes, particularly with military families, there are lots of resources, but nobody knows. No one either knows that they exist or they don't know how to access them or don't know if they are indeed entitled to them. It can be all very confusing. And that number 833 TLC Mama is for everyone, civilian or military, just anyone who's in need of that support. So if you don't know that number, make sure that you write that number down and share it with others. And we have
I'm just bending over. I have a whole drawer of little cards with the number for the hotline. Yes. So like you can download these and give them to your patients, right? And be like, here you go. Call this number. They'll get you connected. Yeah. So I'll lean over again and get them in a second.
And I don't know if are they still available to order? Our organization ordered them. Our Happy Mama Doula Services practice. All the doulas have them. They're business side cards. We pass them out. And then at other larger events, there's a magnet for the refrigerator. So I think they're still available to order. Is that right?
Yes. And I'm going to look up the website and drop it in the chat. Absolutely.
Wonderful. Thank you for that. And while you're doing that, there's a question from those participating. And thank you all for popping your questions in the chat window. The remark here is, thank you for this data. How can we help call attention to this nationally with the current budget recommendations that MMRCs and PQCs are not currently in the federal budget?
I am so happy to take this call because this is what I'm actually working on right now. So let me back up and explain what these organizations are. So MMRCs are maternal mortality review committees. These are committees at the state level that meet. They're multidisciplinary, and they review the deaths of all women that occur during pregnancy or the first year postpartum. And they have access to a wide variety of documents, and not just medical records, but if there are any social services records or police reports, they interview the families. So they're trying to develop a robust picture of why and how this woman died. And these are the organizations that have identified mental health conditions as the leading cause of death. So these are at all states. Everyone has them. They all report data into a federal program that analyzes his data and puts out reports. So those are the MMRCs. And so they make recommendations like here's the leading causes of death. Okay, so then perinatal quality collaboratives, PQCs, are also state-based, and they basically take the information from the MMRCs and say, okay, they've just identified in our state, these are the leading causes of death, so this is what we're going to do to address them. All right, so in some state, it might be, say, obstetric hemorrhage. And so they implement these safety bundles at hospital levels to address this particular thing of obstetric hemorrhage. So it's this whole lovely process, or this is the way it's supposed to work, right? The MMRCs review the deaths, they make recommendations, the PQCs take that information and then drill down and make quality improvement changes. So right now, those two programs are slated to be eliminated by the federal government. So what I've been doing over the last 2 weeks or so is putting together spreadsheets of, okay, what are these numbers? How are they going to impact each state? We're meeting with congressional members on the appropriations committees to say, hey, these programs are slated to be eliminated. Here's what the impact is going to be for our country, but also for your state. So we are actively working with the March of Dimes, with the American College of Obstetricians and Gynecologists to focus on this particularly. So Sue, if you want to join us in this, or you have any other insights, we'd love to have you as part of this, or anybody else who's interested. Please let me know. We'll keep you posted on our work. Literally, this is what I've been working on for the last week or so.
Wow.
Thank you
Wow.
for that, Adrienne. I'll just say that I'm currently at the Association for Women's Health, Obstetrical and Neonatal Nursing Convention in Orlando. And our opening session from Monica McLemore really helped to drive the fact that I'm a nurse by background, that nurses, our numbers alone can help drive some of this change. And that, this is a really critical moment. So I'm happy to help. And there are lots of people that really want to mobilize and move this to get this back in.
Yeah,
So,
and
so thank you for what you're doing. Yeah,
thank you. And A1 is one of our partners in this work. So
great.
And enjoy the conference. I was there last year. Where was it last year? It was in Phoenix. Oh my gosh.
Yeah,
Hot. Yes.
Yeah, it's actually, I'm from Boston. It's actually cooler here than in Boston right now.
Oh, gee. Crazy, crazy.
But thank you for what you're doing.
Let's turn a lens to talk a little bit more about the military. I think I'm correct, and someone will correct me if I'm wrong. But I have found that Humana has been, in particular, one of the payer organizations that recognizes the greater benefits that and outcomes that come from driving value-based medicine and value-based approaches. Doctor, I think it seems to me, I mean, some of the programs seem a little bit more progressive. Maybe there's room to do more, but I think there are a few. Dr. Roscoe, do you mind sharing with us some of the programs, a little bit about the programs and initiatives that your organization is directly trying to lead in terms of addressing some of these behavioral health needs of military families?
Yes. So I guess I'll back up a bit and say, there's Humana, and then there's Humana Military, and we again are the managed care support contractor for TRICARE, and the rules, the benefits, or the benefit of what TRICARE is actually, it's literally determined by Congress, and we get to be the administrator of it, but we follow their rules, right?
Okay.
And so that separates us from big Humana, as we call it, that can be that I guess follows fewer rules or a different set of rules related to value-based care initiatives and that kind of thing. Having said that, I think one of the programs that we're most proud of is our case management services. So we have medical case management, behavioral health case management, and then we have a specific case management kind of specialty program for women at risk of with high risk pregnancies, and whether they've been connected for for medical purposes or behavioral health, we're talking about behavioral health. We're doing that screening, just as Adrian suggested, should be a part of any conversation. So, so we are not the providers, but we get to be a voice and an advocate to women in the military, to connect people to care, and to connect those dots of access to the wonderful programs within the military.
That's really very, very helpful. Are there was a question that was asked around what mechanics are providers receiving, in terms of resources and guidance for behavioral health issues that are expected with mothers, that mothers may be experiencing. Are there any unique programs directly to enable providers in the military setting to try to help with that? Any special
so
trainings or okay?
Yeah, so this is a great point. So the big solution for treatment cannot be to connect a woman with a psychiatrist who specializes in peripartum mental health conditions, because there are just too few. The numbers doesn't work. And frankly, we don't need to refer to that specific of a provider, because a wide range of licensures of therapists can learn evidence-based treatments for that whole list of peripartum mental health disorders, and a pretty big spectrum of prescribers can learn the recommended algorithms, the safety concerns, the effective evidence-based treatments for medication management. So don't just think psychiatrists, think, OBGYNs, family practice, pediatricians. So we got to get this training to these big populations to increase access to care. So that's some of my fun work with Adrian is we're trying to figure out how to make sure that therapists and prescribers who already have this expertise or this ability to offer care become TRICARE providers, and the TRICARE providers that are interested in this kind of training and acquiring this knowledge get the training. So yeah.
Wow, I love that. And it also, as you were listing some of those areas of specialization, I was thinking, ooh, don't stop there, right? And why I say a little progressive is because the military does offer, for TRICARE, it does offer doula services and lactation consultations. And we kind of forget about these little things, but they can be really big instrumental ways. I just go back to this idea of mental health is health. And when we think about, for example, heart disease and stroke prevention, we educate everyone from the barber and the hairstylist to the family at home. Children learn about it, right? The American Heart Association pushes that. Everyone becomes part of the process of, if identifying someone who's signs and symptoms of a stroke, as an example. And so I'm just wondering, what efforts are being made to leverage the other resources, the non-clinical role of individuals within the community and other non-clinical healthcare professionals, such as community health workers, cuidadoras, doulas, etc. Adrian, would you like to share your thoughts on that?
Yeah, you're absolutely right, Fran. There is a need for all of the support. When we think about mental health conditions, they're really on a spectrum, right? There's some women who experience the baby blues, which is like 2 to 3 weeks of sort of after the baby's born, kind of, settling back from the whole experience with pregnancy and postpartum. And maybe like some mild anxiety or depression. They need a certain interventions. Like we said, maybe some doula support, some lactation support, some, family support, some more sleep, right? So right. Then there are women who are significantly depressed or overwhelmed, and they may need therapy. They may need medication. Some women actually need to go inpatient to a psychiatric hospital that specializes. They may need like intensive outpatient programs where they go 4 or 5 days a week and they're with in a group setting with other women. So we have a range of interventions based on the range of severity. And as Sarah was saying earlier, not everybody needs a psychiatrist, right? And so we have to figure out how to intervene and provide the right interventions and save the most expensive and the scarcest resources for the people who really need them the most. And so a lot of this kind of goes back to planning during pregnancy, right? What is it going to be like when I come home with this baby? And first time moms really have no idea what it's going to be like. Second and third time, like, once you have a child, you kind of know the things that you need to put in place. And so we try through various postpartum plans to help parents think about these things before the baby is born. So almost everybody is familiar with the idea of a birth plan. Like, what do you want the birth to be like? Well, I want soft music and candlelight and whatever. But really, the idea is that the mom and the baby are healthy. That's are born and go home from the hospital together. That's the ultimate goal of a birth plan. What we want is parents to figure out and think about what's it like to come home? Who's going to provide meals? How are we going to get sleep? Who's going to walk the dog? Like, how are we going to deal with all of these things when we're trying to keep another human being alive, a person that we've never met and we don't know what their needs are, right? And so again, trying to educate people before the baby's born about the range of these disorders and the stresses of what it's like to have a new baby in the home, and put resources in place before they actually need them.
Mhm.
Right.
You're just speaking so much amazing truth. It's one of the things we do emphasize. It's like, wow, you definitely have been on the front line in so many ways, and
Yeah.
all of you have. And so thank you for the work you're doing. As a reminder, this is our virtual Hill briefing, so we do go a little longer. So for those who are able to stay along with us, we welcome you to continue the conversation with us for just a few moments. I want to turn our attention to some of the tools that help enable that planning, become added resources. We're excited actually to invite the Technology Council of the Maternal Mental Health Leadership Alliance to the Match Coalition for the months of September and October, in which all of them will have the opportunity to present their technologies and some of the efficacy around those technologies. So super excited for that. Let's jump on the technology bandwagon a little bit. Um, is there, well, I guess no one I guess neither of you would probably say, yes, there's enough. But when you think about some of the things, I know, for example, Sarah, Dr. Roscoe, you'd mentioned, oh, in the military, Humana and Humana military, two separate arms, right? Two separate branches, if you will, right? Um, and recognizing that, but how much outside influence, like when there's a budget that's put into place, we know that we know technology works. It doesn't just work to protect us as a country and our and support our efforts around the world. That technology is also good for our health, right? We can use technology in ways for the individual well-being. Does Humana Military kind of look at innovation? Is there an innovation arm or efforts around that? Can you share a little bit of that? We heard from Adrian about those amazing programs. Again, we're really excited to bring, if you guys don't have it on your calendars, September, October, the Technology Council of the Maternal Mental Health Leadership Alliance will be coming to the Match Coalition. But we'd also love to hear about what are some of the efforts, the innovation efforts in technology, even if it's at just a high level. Do you mind sharing it with us a little bit about that?
Yes. So, frankly, over the past couple of years, the biggest way that we've been able to leverage technology is for the benefit of our beneficiaries' health is via access to telehealth, which of course was prompted by COVID. Thanks COVID. At least that's one thing that positive that came out of it is expansion of options and coverage for services delivered via telehealth. And admittedly, when when telehealth became more prominent, psychiatry, we kind of didn't know, are we the perfect fit for telehealth or the worst? Like, isn't being in a room with a patient, isn't that just a critical part of treatment? And it varies person to person, based on their, personality, their condition. But for a lot of people, it works great. It removes so many boundaries, in terms of, geographic boundaries, uh, people that, you know, don't want other people to see their car in the parking lot of the, psychiatry clinic or the therapy clinic, might access telehealth more readily because of that. And it's been a great, it's been a big game changer, I'd say. And it's decreased our wait times tremendously. So we want rapid access to services as well, and it's been a critical tool for that.
That's awesome. And it has been, right? I think we sometimes overlook how long it took us to bring telehealth into the forefront, right? I mean, telehealth had been around since the early 80s, quite frankly, right? I mean, we just weren't utilizing it, very slow to bring it. Do you think there's opportunity to do more there? I mean, I have my own thoughts on that, but I'd love to hear from perhaps Adrian, your thoughts on that, even Dr. Bachman and others, Lavina, Karen, anyone have, I mean, do we think, can we get a thumbs up or a thumbs down? Do we think that that we're where we could be, even again with the use of telehealth? Are we still kind of scratching the surface? I mean, I thought the last numbers I looked at, it was like 35% adoption or something like that. And from a clinical standpoint, in terms of pushing it, not that people aren't demanding or wanting it. Um, any thoughts on that? Anyone want to share? Any comments?
I think one of the issues that comes up is having all the equipment to have a telehealth visit. Number two, having the privacy, so that if I have individuals in the room who I don't want to let know about my problems, that many times you don't have privacy, or you have to go to a library or some public area to get access to the technology that's necessary. And I think sometimes there's also some language issues that are not fully addressed with the telehealth.
Mm-hmm. Mm-hmm. Some very good points there. Although it's starting to be more advanced, even this session today has closed, not only with the closed caption, but translated closed caption if for anyone who chose to use it, which is pretty awesome. It's kind of opening that up for us. But we certainly see there's an opportunity there. And coupling that with Adrian, your comments about broadband access. And I just think back, I don't know, even 10 year pre-COVID, right? I guess that's 5 years ago. Continue conversations with the FCC about how do we get broadband into the places where it's needed. And similar to your comment about using the telephone, we see even in other markets, in other countries around the world, while they have leapfrogged and not gone to the phone lines, they have been leveraging cellular, the flip phone, not the fancy smartphone, but just a basic phone with basic SMS texting is all you need to do an SOS. And that's the way that many, even during COVID, were able to survive, because they were able to drive educational awareness through those platforms.
Yeah.
Would you mind sharing with us how the MMHLA, the Maternal Mental Health Leadership Alliance, has gone about trying to encourage, I don't want to use the word negotiate, perhaps it's necessary. Look, let us in for, because it always is a little bit of a negotiation and a bargaining, right? Deciding what resources or tools, what's gonna be allocated towards some of the efforts that you're trying to push, right? What was that like? Was it last week or the week prior that you mentioned being in DC with these technology innovators, and trying to really bring to the stage on Capitol Hill the need to do more to, number one, preserve and protect what we have in place, and number two, build on top of that. What were those conversations like?
So I have to be honest with you, I was not part of those conversations. I was out of
okay.
town. I was in Montana doing a presentation out there, talking to the Healthy Babies Coalition of Montana. So my colleague Jamie Belcito was on the Hill with all the technology companies, and she's really been leading those conversations. And so, unfortunately, I can't speak specifically to how those conversations went last week. What we do know, though, is that technology, it's not only the wave of the future, it is the current, right? And we can't,
Yes.
we have to embrace and figure out how to make technologies available and safe and secure and help people who don't understand the different technologies understand what they are. Like for example, like a year and a half ago when we started learning about all these different technologies, like it took us a while to sort of separate the wheat from the chaff. What are these companies? What do they do? Because you read the websites and they're like, we revolutionized the healthcare ecosystem. I'm like, well, what does that mean? What do you actually do? And it
Yeah.
took a while to actually figure out what some of these companies do. And so once we figured that out, we're like, oh, now we can help you do it better. So it's also helping them figure out what they do, because a lot of times, they use like tech speak that doesn't resonate with the user, with the end user. And so helping them communicate better what it is that they do as well. Yeah.
Mhm. I think that's an excellent point. Just being in the technology space for so long, and even the work of the Match Coalition, sometimes just, people tend to be parrots, right? They just kind of repeat what they've heard, but they really don't understand, like, well, if you had to break it down, if you can't explain it to a kindergartner, you may not really understand it yourself, right? Can we break it down to the simplest level, which is so important.
Yeah.
And with that, how do technology vendors, are you familiar at all, Dr. Ross, I don't want to put you too much on the spot, but are you somewhat familiar with how these technology companies, these innovators, can go about um, presenting to Humana Military? I know there's process, right, for new tech, and maybe not from the technology itself, but even services. When someone's wanting to come in and provide services, what's the route? What are some of the routes or things that we need to take into account when we begin to consider, oh, I have the greatest thing since sliced bread. How can I, I want to share this with Humana Military. And I'm sure there's many who do, and probably people who approach you all the time the moment you say I'm from Humana Military. Where do you direct them? What should they be thinking about when they start to think about pulling together solutions for the military?
I think I'm not sure that Winnie was able to stay on the call this long, but
Okay.
she's a go-to resource. She's a great contact to have. She's a teammate at Humana Military that works in the innovation space, and so that's one answer. The other is this applies to providers big and small, tech and not tech. We'd love to have you as a TRICARE provider. So that requires getting credentialed, getting TRICARE certified, and that seriously, anybody on this call that wants to find out more about that process, send me an email. And that's that's the next step.
Ooh, that's exciting. That's very exciting. Well, we have gone through an incredible array of topics, everything from, again, the prevalence, approaches to prevention. I can't thank you both enough for emphasizing the signs and symptoms. And I know you didn't call it signs and symptoms, right? But when you say things like not managing their health, having poor nutrition, not going in to see their providers. The idea that someone is frequently moving, right, which everyone hopefully knows is considered one of what do they call that? A major life change. Moving is a major life change. Lack of social concerns that someone may have about wanting to harm themselves. And you highlight the dual military relationship, right? Both individuals. And when I think about those, just when I think about it from the standpoint as an epidemiologist and as a doula and our doula practice, I think about these families. We do support TRICARE families. We think about it in relation to our rural family. Everything that you all have shared with us today, that you've both shared, just keeps ringing the bell. Those are the alarms, and we should all be looking out for that. And I do believe that as you know, even just in our own families, as family members in any family dynamic or makeup, we all share a responsibility to each other. And that family can be the people under your own roof or in your community, and taking the opportunity to really heed some of the advice that you all have given today. We greatly thank you for it. And I want to once again, remind you of the number 1-833 TLC Mama. We talked about language support. It's available both in English and in Spanish. And I want to double emphasize one thing that I did learn, that it's not just for the moms. It's for any family member can call. The father can call. The grandmother, that supportive person for that mom, can call that number as well, and it can be then adequately directed to needed resources. But most importantly, encouraging moms to call. It's confidential. It is free. It's 24/7. And that to me is amazing. And someone had said they thought the number had gone down because, all of the talk about the funding and the budget cuts. And I said, no, I don't think so. I just gave that number to someone yesterday. And I picked up the phone, I rang the number just to make sure.
Yeah, so unfortunately, the folks at HRSA, the Health Resources and Services Administration, who are managing the hotline, lost their jobs. But the hotline is running 100%. It's intact. Yes, answering calls. I called the other day too, just to be sure. Yep.
Well, I have to say again, Adrienne and Dr. Roscoe, thank you all so much. This has been so informative. I'm excited for us to continue to share this information as part of the Happy Mama Expo coming up in October, as well as seeing all of those viewers who are going to view this online through our YouTube channel. And again, thank you, thank you, thank you. If anyone has any questions, what would be the best way for them to reach out to you?
Via email. I'll drop my email in the chat.
Perfect.
Me as well.
Thank you. We'll just take a moment to do that, and everyone can grab the numbers or the email addresses rather. And again, I want to thank the commitment that the Maternal Mental Health Leadership Alliance and the Humana Military has made to such an important topic in maternal health, and again in health, in general health, and health overall for all families across the country and stationed around the world. Thank you all so much for your time today. Everyone, enjoy the rest of the beginning of what seems to be a very hot.
Thank you, Fran, for having us, and for everybody for being here today. Really appreciate your time.
Thank you so much.
Thank you all.
Thank you. Thanks for all you do.
Thank you. Thanks for joining.